Well, I just spoke with Dr. Mike Wasserman, and it was a very enlightening conversation. He has been the CEO over a large nursing home chain in California. He has been the medical director. He's been the administrator. He's been everything in between. He's a geriatrician, and so getting his perspective on all of these things has been really interesting. We talked about the importance of getting CNA representation on your QAPI board so that you're getting the boots on the ground feedback, the importance of doing the same with housekeepers, what got him into geriatrics in the first place, and just a number of concepts that were just eye-opening from somebody who has been in every seat in the book. So you're going to enjoy this one. Let's get into it. Well, first off, thanks so much for jumping on the show. Really appreciate it.
Thank you for asking. I have trouble saying no to folks who want to talk about this stuff.
Hey, I'm the same way. If anybody wants to chat about it, I am available. So I also it feels like I caught you at a good time. You're here in LA. Is that right?
Yes, I am. I'm actually out in Buena Park right now.
Buena Park. Oh, that's awesome. Are you here for business or for pleasure?
Now, my mom is 88, and on Friday I moved her into an assisted living facility. So
gotcha.
I'm here living the stuff I've been doing for nearly 40 years.
I love it. So this conversation is near and dear to your heart.
Yeah,
It is
absolutely.
it is a timely conversation. Well, I love it. So Mike, let's start off with this. Why don't you tell the people a little bit about who you are? Condense your whole life into 2 minutes.
Yeah, I'm a geriatrician. And really that's most of my life. I've really just loved, even as a kid, I loved being around older people. And then I found myself in medical school gravitating to geriatrics, and I went into practice doing geriatrics. And that's where I've sort of lived and breathed for the last 40 years. The pandemic added a whole new set of skills for me in terms of dealing with the media, dealing with politicians, dealing with government officials, trying to affect policy and change. It also reminded me about the failures of poor leadership and the importance of good leadership in most arenas, but the post-acute and long-term care milieu is one that needs great leadership. On a personal note, I exercise sometimes to extremes because I believe as we get older, exercise is the single most important thing we can do. And trying to devote more time to my wife, who's been very patient with me for 44 years, and my 2 grandchildren. So that's it in a nutshell.
Mike, I'm going to start off by saying that if I had ever run an Ironman, that would be how I describe myself. So the fact that you didn't describe yourself as having done how many Ironmans?
16.
16 Ironmans speaks to a level of humility that I aspire to. So what you talked about working out even to the extremes. Is that Ironmans that you're doing to the extremes, or are there other aspects?
Well, I've taken Ironman off my plate for the last few years. May come back to it someday if I have nothing else to do. I'm aiming more for the half Ironman distance just because I think it's healthier for my body.
Sure.
It's what I've recently learned. Instead of trying to be as fast as I can or doing as much as I can, I'm 67. I should practice what I preach with patience. And what I stress now is resiliency and durability.
Yeah.
And so I've always been really bad at doing strength work and core exercises. And it came back to haunt me about 7 weeks ago when I muscled through a half marathon despite having a back injury, and I just made it worse. And but the good news is, and I'm one of these people. One of my mentors once said that if I walked into a room full of horse manure, I'd ask, "Where's the pony?" And so I've taken this whole situation as a reminder that I really have to focus on my durability and my strength.
The fact that you're saying that you're muscling through half marathons, I can barely muscle through a couple miles. So I'm sensing a lot of toughness. I think a lot of resilience. It sounds like you are practicing what you preach. I want to actually jump back to something you said though, because it's too good of a quote not to say twice. But you walk through a barn filled with horse manure, and you ask where the pony is. Have you always had that sense of optimism? Has that come over time, or has that just been a natural personality trait?
I think it's just me. I think it's genetic. I think it's who I am. I think I got it from my grandmother, who was arguably the most non-judgmental person I've ever known.
Yeah,
And over the years, I've allowed myself a little judgment at times, but by and large, you have to do some really bad stuff to get me to judge you. So
yeah.
I'm always looking for the best in people. I'm always looking for the best in, the best in our opportunities. Yeah.
I can already tell this is going to be a fun conversation because I like talking to people who view the glass half full. So
Yes.
another thing that you mentioned was just that early on you gravitated towards working with geriatrics, which is a great thing to gravitate towards. It's such important work. At the same time, it's probably like I would say a less attractive form of medicine, right? Working with geriatrics. Yeah, I'm sure that there's, quite a few people who do get into it, but it's not your emergency room, medicine, the fast-paced stuff. Um, what was it that pulled you into geriatrics early on?
You know, number one, I think it's whatever floats your boat in the sense of why do people go to medical school? Do
Yeah,
they, do they go to medical school because they were really good in the sciences and
yeah,
they're sort of scientists and, but they don't have a lot of people skills and, or do they go to medical school because they really want to help people and they like people and they're people persons?
yeah,
Which is an interesting question for how we pick people to go to medical school. I always appreciated the sciences, but like I said, as a kid, when the family would get together, I'd always find myself sitting around all the older folks, listening to their stories and listening to them talk. And to me, geriatrics is just a wonderful. There's so many specialties these days that
yeah,
everything is kind of cookie cutter.
yeah,
Like, this is what you do, this is how you do it. When you're taking care of one 95-year-old woman, you're taking care of one 95-year-old woman.
yeah,
And they all have stories. It is truly the art of medicine. I always say it's sort of like practicing country, being a country doctor.
yeah,
And so I think number one, it really allows you to use all of your uh, critical thinking skills, but it also allows you to sort of have a thumb on your humanity. And I mean, the number of times I would just realize sitting in my office talking to one of my 90-year-old patients and hearing their stories. It was always really, really pretty cool.
yeah. Did Did the business naturally take you into, rounding in nursing homes, skilled nursing facilities? Is that kind of how you started out, or did you start doing kind of another aspect of geriatric medicine?
Yeah, that's a funny story. When I did my geriatric fellowship in 1988 and 89, I did, and I learned from two of the grandparents of nursing home medicine, uh, Dan Osterweil and Joe Auslander, and they literally wrote the book. I left my fellowship and went to work for Kaiser Permanente in Southern California, Woodland Hills, and I actually had no interest in doing nursing, but
Okay.
it didn't take me more than probably 6 months to realize a term I've used often: if not me, then who?
Yeah.
And I'm a geriatrician. I got nursing home care. I looked around to see who else was doing it. And before you knew it, I was doing nursing home care. I also opened Kaiser's first outpatient geriatric clinic in the country back in 1989. And then their second continuing care department in the San Fernando Valley in 1994. And so the nursing home piece just came about. And then, when I went into practice, I moved to Denver, ran a healthcare company, then went into private practice. Ultimately, in the 2001 to 2010, our practice grew multifold. And about 50% of our practice was in nursing homes and assisted livings and group homes. And about, say, 25, 30%, actually 50% nursing homes, 25, 30% clinic, 15% assisted livings and group homes, and then house calls as well. So we touched the lives of about 15,000 Medicare beneficiaries in Denver when we sold the practice in 2010.
So it sounds like, and just kind of looking at your background, so you have worn lots of hats when it comes to working in nursing homes. I just from when you were talking, I counted physician, I counted CEO running a company, right? What from looking at those different roles, how has that changed the way that you think about nursing homes, and specifically, I'm interested to know how you think a nursing home should operate after having all of those roles.
I think all of those roles have really helped me to form what I consider to be much more informed opinions on these topics. I scratch my head wondering how nursing home chain CEOs can have a clue of what's actually going on. So, they'll talk about, we're going to provide quality care. Well, I'm sorry, but most of them wouldn't know quality care if it hit them in the face. Okay. And the bottom line is it's not, and many of them mean well, but their background is not. I mean, I'm one of the very few geriatricians to have ever run a nursing home chain. I might be the only one. I'm not sure if there's ever been a geriatrician overseeing the operations of a large nursing home chain before or after me. And I hate to say this as well, though, as you can tell from looking at my background and history, I rarely have an issue saying what I think.
That's what makes a great podcast guest. Just FYI, that's why we have you on the podcast.
Oh God. It is, you need to understand the clinical aspects to understand what quality care is. And with that said, the balance of that, and I think the problem is very few clinicians have a clue how to run a business. And so you end up in this almost impossible situation where if you put folks like me in those leadership roles, in those executive roles, your business might fail. So I think the most profound thing I came up with near the end of my tenure running a large nursing home chain was the concept of the three-sided scale. And I use a scale. One of my friends likes to think more people understand the three legs of the stool, but I use the scale for a reason. When you're a CEO, you've got people reporting to you. You've got operations reporting to you. You've got finance reporting to you. You have clinical reporting to you. Now, those are the three things. Those are the three major groups that I see in long-term care. And actually, even at the nursing home level itself, if you looked at the administrator of a nursing home, they're dealing with finance, operations, and clinical as well. And so the thing that I've seen in the industry is finance is king. Finance drives everything. Okay. And operations is sort of right up there. Okay. In terms of importance, if you will. But clinical gets pats on the back and platitudes, and we're trying to do the best we can in quality, and we're doing blah, blah, blah. But go look at the clinical departments and compare them to the finance and operations. Look at the reporting relationships. Look at accountability. You don't find it. And And so my goal was, and I believe this should be the North Star of all nursing home chain, post-acute long-term care chain CEOs, is to put your thumb on that scale to make sure that operations, finance, and clinical are equal. And you want all of them to be excellent.
Yeah. So, Mike, just talking about this operations side, clinical side, finance side, I don't know if it's a direct alignment, but I think about the medical director at a nursing home. And I think about the director of nursing at a nursing home. And then I think about the administrator. And I'm curious to know, because I think that the medical director is oftentimes a very underutilized resource at the nursing home. Describe how a young administrator like myself should be interacting and utilizing the medical director in order to get great clinical care at and really just improve all clinical operations at the nursing home.
Great question. I'm thrilled you asked it. Much experience in this realm. Number one, embrace that medical director. Let them know that they're important, they're valuable. Also, make sure that you've got a medical director who knows their stuff. So, the simplest way of doing that is to make sure they're certified by the Post-Acute and Long-Term Care Medical Association, that they're a certified medical director. And actually, are you here in California?
I am. Yeah, I'm here in Tustin in Orange County.
Okay. Oh, yeah, you're around the corner.
I'm right here. Yeah.
So in California, as of almost 5 years ago, every medical director in the state is supposed to be certified.
Okay.
The California Department of Health has not enforced that. I don't know what they're doing, because it's the law. And so, we had the foresight and and by the way, the bill, AB 749 in 2021, that passed the state assembly and state house with no nay votes. Think about that. California, I mean, granted, we're kind of a blue state, no nay votes in the House or assembly, or in the assembly or Senate. And that bill requires every nursing home medical director to be or get certified. So you have a leg up that hopefully your medical director is certified. If they're not, they need to be in the process of getting it. The certification gives them the tools and the knowledge that they need. I was on the faculty of the course that does the certification. We had a number of California medical directors who had been medical directors for 30 years that said, "Oh, I'm forced to do this. Wow, I wish I'd done it before. This is really cool. I'm learning a lot." So look, despite being an optimist, I'm also a skeptic. And so when I say something, you can be pretty sure that I have questioned it like a gazillion times. And so even though I believe that the certification matters, when I'm teaching the course, I'm asking the people taking the course, are you learning stuff? Is this valuable to you?
Yeah.
And so that's number one. Make sure they've got the competence. But
and Mike,
then make sure.
Just before we jump into number two, what are some of the things that get taught in this course for medical directors? How is it teaching them to, I guess, be more engaged, right? Like, or be more effective in a nursing home?
Well, it's broad. So it teaches them everything from the regulations that you're under to the finance and the challenges. And we'll come back to this. One of my favorite topics and areas is a really high quality medical director with knowledge of geriatrics should pay for themselves multiple times over by engaging them in your Part A pharmaceutical costs.
Okay.
So that's the kind of thing they should understand and they have knowledge of. And then you get to QAPI. And there's a whole science behind QAPI and understanding how to run QAPI, how to do QAPI projects, how to do PDSA, how to do the whole, how to do the whole performance improvement stuff. And then finally, not even finally, but leadership, understanding emotional intelligence, understanding how to interact. It's a medical director can be a leader and can really help you because whenever I would go into my nursing homes as a medical director, I would always take time. Now, look, even as CEO of a nursing home chain, I spent one summer going to all 75 of our facilities in California and speaking to the CNAs, the housekeepers, the LPNs, the nurses, the residents. But as a medical director, the number one person I'd want to speak to would be the CNA and even the housekeepers. Those housekeepers, they're in the room with the residents and their families. They know stuff. And the one thing I learned long ago as a geriatrician, when a family member or anyone on the staff says, Mrs. Smith just doesn't look right today, believe them, trust them, take
Yeah.
that to the bank. And so when you have a medical director who's asking the opinions of your CNAs, who's
Hmm.
validating their role, that's powerful.
Yeah.
So I think the leadership aspect, and then, being that bridge. By the way, you also have to know your facility. I've been medical director of a facility where the DON really runs everything. And I've been in facilities where the charge nurse on the second floor is really the one running everything. And I've been in facilities where, there's weak nursing leadership or there's weak administrators and strong DONs. And look, the DON and the administrator are the linchpins. If you've got a high quality, great facility and you lose either the administrator or the DON, look out. You can go bad really fast.
Yeah.
And that turnover, I just saw an article on this, which is like, yeah, duh. Yeah, turnover of administrators and DONs is probably the most significant prognostic finding of a nursing home turning downwards. So, uh, but yeah, so engage your medical director, let them know that they're valued, that you want their opinion. And actually now, so before a few years ago, I couldn't tell you this. I could tell you should do it, but now I tell you have to do what I'm about to tell you. Every nursing home is required by the Centers for Medicare and Medicaid to do an annual facility assessment. And that facility assessment has to be kept up to date. So let's say you're admitting a vent patient, or you're admitting, because you have a facility that does that, or you're admitting a really complex patient. You have to look at your facility assessment and say, do we have the staffing to handle this? Do we have the resources to handle this?
I just recently went through a CMS survey and they did ask for my facility assessment and they did go through it in detail with me, right? And so it was very much here's my facility assessment. It's an open book. They're flipping through it. They're asking me questions about it. They're wanting to make sure that we have worked with all of these different individuals. And so everything that you're saying very much it's real. It absolutely is the case. You have to spend some time on that facility assessment.
Well, kudos to the surveyors because they're supposed to do this. Doesn't mean in all states at all times that they
Mhm.
do it. To me, there was so much noise and politics around the staffing requirements and mandates. I didn't care.
Yeah,
I took some flack from, even though honestly I supported the mandates for some very practical reasons based on my experience. But at the end of the day, as a lot of the advocates were like disappointed that the mandate sort of went down in flames, I'm like, guys, the facility assessment is still there. And the facility assessment still provides the path for assuring appropriate staffing.
yeah,
And I think it's really, I'm sort of keeping an eye on what's going on at CMS now. And keep in mind, there's a difference between CMS and the state survey agencies. That's a whole other topic. We could probably do a whole show on that. You would think that they're all rowing in the same direction, but no, they don't.
Oh no, that would be too easy, Mike.
Yeah,
That would just be way too easy.
but the facility assessment, and I've written some. I wrote an article in McKnight's sort of laying out how to do a good facility assessment. There's some good papers on how to evaluate your nursing and everything else. And keep in mind, at the end of the day, if you have a top-notch medical director and DON and great department heads, I think the opportunity to be innovative, creative, I have a lot of people say, well, you don't necessarily need nurses to do X, Y, or Z. And they're right, but only if you actually have the people who can fill those, check those boxes
Yeah.
to provide the care. And that's a whole different story. And I've
Yeah.
seen that. Activities people can be tremendous. Restorative folks and therapy folks and aides. There's a lot of folks out there who can, it is a team. There's no one person that's everything in your facility.
Yeah, absolutely. In terms of, getting that cohesive unit, because I think that's what we're talking about, right? Is that everybody has a part to play in the financial side of it, the clinical side of it, the operations side of it. Even, your activities person has a huge, part to play in the clinical side. Your administrator has a huge part to play in the clinical side. How do you encourage everybody to play that part, right? Because oftentimes the administrator is only focused on finance, right? Or operations, right? Your DON's only focused on clinical. How do you foster that in the building?
You're basically describing what has been generally called the culture change
Yeah.
movement. And it is about culture. And though, it's funny. I'm not sure I would have chosen that word. But it starts at the top. And with that said, uh, more and more I've gotten away from the idea of champions and stuff like that. And I think we can harness the compassion, the caring of everyone. I mean, I've written about this, that the folks who work in nursing homes are the most compassionate, caring people that I've ever met. And that starts with the, housekeepers and CNAs and maintenance people and goes all the way up to the administrator. And harnessing that compassion, supporting that compassion. And that's where the leadership stuff comes in is, uh, we're human. We make mistakes. It's the whole, it's that, uh, not when someone makes a mistake, not beating them up,
Yeah.
and which, by the way, has been one of my decades long critiques of the survey process. And I've shared this with CMS. We wrote a paper on it a few years ago. Uh, when you survey a facility and you leave and the staff is demoralized, how have you helped care? And that culture, that attitude, that morale is critical. And so I think as leaders, we have to know our people. And I have a friend and colleague of mine who's just a brilliant speaker on the topic of emotional intelligence. And I'll tell you, uh, I had my eyes opened to things I never thought about, right? In terms of understanding emotional intelligence, being able to look at people and know, I'll give you an example of of a circumstance when I was in my actually I was chief medical officer at the time, and I visited a facility. It was in a rural area, and I asked there was a team meeting going on, and I asked the administrator if the CNAs felt comfortable going to the nurse and letting him know that, say, they were concerned that Mrs. Smith wasn't looking good. And the administrator looked at me, and she literally pounded her fist on the table and said, "My nurses, absolutely, they do that because I tell them to." uh, I looked over at one of the CNAs and I could see abject fear in her eyes, emotional intelligence, reading the room.
Yeah.
I will tell you that when I became CEO, funny thing, that administrator didn't last very long. So, but, and I will say they were given chances because I believe in giving people chances. But
Yeah.
I learn every day how little I know. And I think being a little bit humble as an administrator, not assuming you know everything,
Yeah.
but you really have to, you got to lead the way with positivity, and you can't beat people down. Uh, I mean, with that said, I have seen businesses, I have seen nursing homes that are run by people who are tyrants, and you can actually run a somewhat decent place up to a point. There are businesses out there that have been highly successful to a point. I believe that you got to pay attention to the emotions
Yeah.
to get the best out of people.
Was just about to say that if you are running the facility like a tyrant, right, kind of ruling out of fear is how I'll put it. It's so hard to keep and retain top talent because if they're top talent, they've got lots of options and they're going to go someplace where they're treated better. And so being able to retain top talent really comes down to building that culture. And I've always been trying to push this culture of we help out. We're team members. We work well in teams, right? It's a lot easier to say than it is to build, right? Because at the end of the day, people are working at the nursing home to make money, right? It's a job. They want to provide for their families, but also giving them a purpose helps so much. And you know, yeah, letting people kind of understand that purpose and let that sink in. It can foster that team mentality, and then all of a sudden you get people going above and beyond. You get the activities director who's really pouring in some thought and effort into those activities, how they can reach the one and those sorts of things. And so I totally agree with you. I wanted to move us into a little bit more of kind of getting your perspective on things. So, after seeing the healthcare system and specifically nursing homes from almost every angle, what change would most improve the lives of the nursing home residents?
Wow.
It's an impossible question, but I'm going to ask you to do it.
No, I'm not sure it's impossible. I actually think what I talked about, empowering, engaging, assuring that the clinical voice has equal influence in decisions. So you've got to look at your facility and your ability to provide the best care you can. If you're sitting down with your DON and your medical director and your department heads, and I'd say a representative CNA, okay, I think it's CNA's voice has to be heard. It's essential to
Yeah.
not have one of your CNAs almost in a lead CNA position. I think is a lost opportunity. Having all those folks and saying and being honest. That's the beauty of QAPI. In a QAPI meeting, no one is higher than anyone else. There's no chain, there's no hierarchy. And that's where QAPI can be very valuable if you're approaching an issue from a QAPI perspective and you've got your QAPI team there. And literally you might make staffing a QAPI project. Are we staffed appropriately to provide the best care we can? And you've got everyone there. And your finance, at the actual nursing home level, your finance person's pretty much going to be you. And depending on whether you're part of a chain or corporation, there may be a finance person above you. What the heck? Invite them in, you know? And you know what? If there's a clinical person above you at the corporate level, like a VP of clinical and a VP of finance that you're interacting with, invite them in. No plausible deniability here.
Yeah.
Know that
Yeah.
your DON and your medical director and your CNAs, this is a safe place. Okay. So if you're finding that on weekends, you're finding yourself with one CNA covering 20 residents and the CNAs are just losing it. They can't do it. They're
Yeah.
overwhelmed. You need to hear that. And as a team, you need to figure it out. And honestly, I think it comes down to that. That's where the leadership matters. It's not, and by the way, great study done in 2009. I've shared it in lectures and such, looking at different types of leadership, consensus style leadership, or also known as servant leadership. That's what I'm talking about.
Yeah.
When you have everyone weighing in and their voices matter versus what's called the autocratic leadership style, where you just decide what to do. Now there's a I'm blanking on the term for it, but there's sort of an autocratic style where you get everyone's opinion, but you don't listen to them.
Yeah. Yeah.
In some regards, that's worse because you piss everyone
Yeah.
off. But if you really do consensus leadership, and the studies, they look at 4,000 nursing homes. Nursing homes that ran with consensus style leadership had significant improvement in their quality measures and significantly lower turnover. The data's there.
Yeah.
This is not rocket science. So I guess I've come to I've given you, I tend to do this. I went the long route to explain my answer. Consensus style leadership is the single thing. And in my opinion, CMS and the state survey agencies need to figure out how to survey around whether you're practicing a consensus style leadership.
Yeah. Well, so I've gotten lots of takeaways from this, right? I think the reason I love doing this podcast is because I get to talk to people and get their perspectives and improve the way that I operate. And I think my big takeaway is getting CNA representation in that QAPI and just in general, having a lead CNA. That is gold. And so I really appreciate that, Mike. That's a great insight. And obviously, not downplaying, consensus leadership and servant leadership. That's so important as well. But that's a very novel idea, right? Of making sure that you're getting CNA advice.
I'll add one more person to your QAPI team.
Yeah, let's hear it.
Your ombudsman.
For QAPI.
Engage your ombudsman. Invite them in. They may or may not come, but a really good, interested ombudsman would jump at the chance. Because when you look at the history of ombudsmen and what they're really supposed to do, ombudsmen are not just about individual complaints. Ombudsmen are about oversight of systems. So, there are ombudsmen in the banking industry. They're not just looking at whether Mrs. Smith didn't get her, they're looking at the system. So historically, you look at the history of ombudsmen outside of nursing homes, they're system oriented. Mm-hmm. So the really best ombudsmen want to engage in whether your system is providing the care. And they're supposed to be there to be the voice of your residents as well. So that's the other ones to add on.
Okay, I've got 2 to add. There we go. Because I have not been inviting my ombudsman. I have, I've had to go through kind of a change in how I view the ombudsman, because at first when they came into my building, it was very much like oh no, the surveyor's here, right? And then I started to realize that they're very much an advocate for the patients. And if you get a really good ombudsman, they actually very much help out the facility, right? Because they add an additional voice of reason, right?
Absolutely.
Yeah. Yeah, but adding them to QAPI, that's another new one. So I appreciate that.
About a decade ago, I went around the state with the state ombudsman giving talks on. I used to give a lecture called "It's Not Always a UTI."
Okay.
Because as you know, everything's a UTI, but it's
everything's
not.
a UTI.
It's actually rarely a UTI.
Yeah.
The problem is if you check the urine of your residents, you're going to find that half of them have dirty urine, but that's just. You can toss a coin. It has nothing to do with UTIs.
Yeah.
And the idea of engaging the ombudsman at the time was just what you pointed out. If we had the ombudsman educated, when the family would come and say, or call and say, oh, my mom's doctor always gave her antibiotics for her UTIs, to have the ombudsman support the fact that, no, it's not a UTI. And if we give your mom antibiotics, she's going to get C. diff, and then she's going to have diarrhea, and then it's going to get worse. The ombudsman can be really, really powerful on your side to help educate families.
Absolutely. Absolutely. To those listening, engage your ombudsman. That's takeaway number 2. Mike, I wanted to just get your insights as a physician, right? Because I think you bring a lot of knowledge to just this role. Who are some underutilized department heads at the building? Who are just like that CNA is, we need to be getting their feedback. Who are some because everybody knows the administrator, everybody knows the director of nursing, right? Everybody, praises the marketing director that can fill up the building. Who are the unsung heroes in the nursing home?
Um, Boy, it's a tie. It's a three-way tie. And probably even more than that. But the
Yeah.
three-way tie would go social work, social services,
Okay.
which are underutilized, understaffed. There's literature. There's evidence-based literature demonstrating the value of social services in nursing homes. So a good geriatric social worker is worth their weight in gold in dealing with families and helping with advanced directives and doing all sorts of things. And if you're running a post-acute, you got to figure out where the person's going to. So you need that person. Activities, I would say, I think activities are generally really appreciated. I don't think we appreciate how much activities people can offer.
Yeah.
And the final is, I've mentioned them several times, the housekeepers.
Those
I think they're the
housekeepers.
unsung heroes. I think you'd be amazed at how much your housekeepers know about your residents and what's going on in the facility. And let's face it, during the pandemic, they were essential.
Oh, yeah.
So, and honestly, during any sort of infection or, I mean, when it's flu season or whatever, they're doing their job, keeping things clean, wiping things down. Uh, C. diff isn't a great example. All the things that get transmitted by touch, but it's not just their job as house cleaners and housekeepers. It's what inviting them in to share their knowledge about the residents. And oh my God, you're giving them a gift too, because they will give you so much more when they feel like, wow, they care about what I think.
Yeah. How have you seen people create that feedback loop? Is it as easy as just going to the housekeeper and getting their insights? Or because I would imagine you want to build a consistent feedback loop where you're consistently getting the feedback. And frankly, it sounds to me like you're talking about getting the feedback from the boots on the ground, right? Which is the CNA, which is the housekeeper, which is your nursing staff, which everybody who's having that firsthand interaction. Is the feedback loop QAPI? Is the feedback loop the administrator goes and interviews them? What does that feedback loop look like?
Yeah. QAPI's one place where you can live it. I think an administrator who shuts their door and is never seen is not going to achieve this. An administrator who spends a lot of time out on the floor, expressing interest, asking opinions, bolstering that. But it's not just at that point. It's making sure your department, because look, I've been in various leadership roles. Uh, you have to look at your chain. I'm a huge believer in the chain of command on many levels, but I've also learned that if you're at the top and a person one or two rungs down from you isn't doing what you do, then your approach is not going to make it all the way down. And so you've got to be aware of what those under you are doing, what the department heads are doing. Um, and again, as I mentioned, there's a lot of culture stuff that you may have a nurse that's been there for 20 years that has a huge influence on the building, good or bad. You got to be aware of all these things. And, those are the tough decisions. That's one of the things I don't miss. One of the reasons I'm thrilled to be retired and not running any businesses is I don't have to deal with personnel.
Yeah. Yeah.
And the reality is it's human beings. And no matter how hard you try, no matter how much you lead by example, you're going to have people who aren't listening to you. You have to ultimately, I had a mentor and a friend who used to talk about the totem pole. And that is, you got to keep that totem pole cleaned out. Like you're going to always have people at the bottom
Yeah.
who aren't doing their job, who aren't cutting it. You've got to be willing to move them out and replace them with new people. And so that's the hardest thing. And I've run large companies. I've run medical practices. Getting rid of physicians is a really tough thing to do. But I've done it.
Yeah.
And I've had physicians the funny thing is, first person I ever fired in my life was my office manager at the first clinic I operated, I ran, and she had just come back from maternity leave and she had her little baby on her lap when
Oh
I
no.
fired.
Oh no. Oh.
And, at the end of the day, though, most of the people I've fired over my career, some of them have come back and thanked me. Some of them have pointed out that they kind of needed that kick in the pants to change or get it right, and I think that's, a lot of us are like wary of, we want to give people more chances and they've got family and stuff like, I mean, I get all that, but you give them chances, you give them direction, but sometimes that honest, you're not cutting it will hopefully be a wake up call for them to get it right. So, you just got to be aware. That's the hard part. And if you're not boots on the ground, if you're not developing those relationships with all sorts of staff, with the caveat, you got to be careful. I do believe in chain of command.
Yeah.
And there's a great scene in Saving Private Ryan. They're walking across the field describing the chain of command. And, you never complain down the chain. And so you want people to complain to their supervisor and that supervisor above them. If they don't get satisfaction, then they can go above the person. And you got to be careful as a leader not to cut through all that. So you want to encourage people to complain up the chain of command and not to come directly to you. So there's a little nuance to that I probably need to remember every time I talk about this.
Yeah, absolutely. Well, Mike, thank you so much. This has been awesome. I have taken away several tidbits that I'm going to be applying like tomorrow at my facility. So thank you so much for doing this. Thanks for listening to this episode of The Nursing Home Operator. If you enjoyed the show, we'd really appreciate it if you'd subscribe, leave a review, drop a comment, or share it with someone in the industry. We're a new podcast and every bit of support helps us grow. If you'd like to be a guest on the show, suggest a topic, ask a question, or share some feedback, there's a link to our Google form in the podcast description. We'd love to hear from you. Thanks again for listening, and we'll see you on the next episode of The Nursing Home Operator.